Hello, friends. It's exactly 2 months since I started. Instead of 58 lectures, there are only 40 because in between I didn't have classes whenever it was coinciding with either Karnataka state webinars or other webinars where I had to speak or whether I had to give introduction or sit as a chairperson. So let's continue with the monochorionic twins diagnosis and management today without wasting the time. Thank you very much for listening to all my lectures attentively, both live as well as on the YouTube. May I request all of you to subscribe to the channel so that you will get notification and you will be able to access the previous lectures as well. Without wasting time, let's go into the topic. Yesterday, I was talking about the diagnostic part. Today, let's look at the monitoring of TTTS. It is same for TAPS as well as selective FGR. That is, serial fetal ultrasound examinations are necessary and consultation or co-management with fetal maternal medicine wing is also important. The screening protocol consists of, in the first trimester, that is 11 to 14 weeks, assessment of gestational age and estimated date of delivery, assessment of chorioamnionicity, and measurement of nuchal translucency. Whereas between 16 and 18 weeks, fetal size is important, early fetal anatomic survey, including presence of size of fetal bladder. Why I have highlighted bladder? Because you will soon realize in Quintero staging, the presence or absence of bladder makes the stage different. Maximum vertical pocket of amniotic fluid should start from now. Doppler measurements of MCA PSV also should start. Doppler measurements of end diastolic velocity in the umbilical artery and assessment of placental discordance, echogenicity, that is called PDE, also should start now. Then 20 weeks, we would do a detailed fetal anatomic survey, including the presence and size of fetal bladder, MVP, and here the highlight is on echocardiogram around 20 weeks. Doppler measurements will continue and PDE also should continue. 20 to 22 weeks, you start measuring the cervical length. Some people start at around 16 weeks also, which is not wrong. Then 22 to 32 weeks, it is the serial growth scan that we do every 4 weekly to detect the selective fetal growth restriction. And serial examination of the following should be done every 2 weeks. In addition to that, growth, that is MVP, presence and size of fetal bladders, Dopplers, and PDE. 32 to 36 weeks is the time we have to plan the delivery. You continue serial examination of fetal growth every 4 weeks, but now the highlight is on biophysical profile score. Weekly, we have to do that. Dopplers will also continue, and you will also look at the placenta. How do we interpret TTTS, TAPS, and selective FGR? As you can see here, the fluid discordancy, to make it very obvious, I have put 5 plus in the red color as far as TTTS is concerned. That is oligohydramnios in one sac and polyhydramnios in the other sac. Whereas this fluid discordancy is not seen in TAPS. TAPS, as I told you yesterday, is a milder version of TTTS, very mild version, I should say. In selective FGR, fluid discordancy is there, but just I have put 2 plus and in black. Of course, there will be oligohydramnios in one sac of the FGR twin, normal amniotic fluid volume in the AGA twin, no polyhydramnios. As far as the MCA Doppler discordancy, what is that? More than 1.5 MOM in donor or anemic. In the other one, it is less than 0.8. As you can see, this discordancy is huge in TAPS, whereas it is not that evident in TTTS and SFGR. TAPS is the one which gives rise to anemia. Growth discordancy. Well, all the red plus have gone to the last column, that is selective FGR. The growth discordancy should be more than 25% difference between the twins. It will be there in TTTS, but not so much. 50% will have estimated fetal weight less than 10%. TAPS, it is there, but only 1 plus. But in selective FGR, I've given 5 plus, and 100% will have estimated fetal weight less than 10th percentile. What about fetal bladder discordancy? In TTTS, it will be small in donor, whereas it is enlarged in recipient. There is not much of bladder discordancy in TAPS and SFGR. What about ductus venosus abnormalities? 5 plus for TTTS, plus only for TAPS and SFGR. Hydrops, again, all the 5 plus for TTTS, not at all for SFGR. There's no question of hydrops at all in FGR. Placental appearance, in TAPS, it is big. Donor side, hyperechoic, and thickened recipient side, normal placenta. But what you must remember is that not necessarily mutually exclusive of each other. So there can be overlap of all the points what I told you. As you could see, there was nothing, very rarely there was dash. Otherwise, it's the question of how many plus is on one column. Sometimes it is 5 plus in one column, sometimes it is 3 plus, sometimes it is 2 plus. So there are all the problems of actually interconnection between the vessels. There will be some amount of discrepancy, but you should diagnose them correctly based on which side is the balance tilting, and can be present together in any combination. So a given lady, of course, TAPS is the starting point, maybe the worst end of the TAPS is TTTS. There can be SFGR also in that particular lady. So all the three may be present. Now I come to the management of TTTS. It's very, very important to understand this, especially for the postgraduates. Primarily, there are 3 approaches. What are they? Expectant approach. Don't do anything much. Just wait and watch. In fact, we have been doing that for years now. Till fetal medicine developed, all we did was expectant management, and that actually helped. In fact, we very rarely had problems. What does it mean? It means TTTS was not so bad in them. It was mild, manageable. Of course, there were losses as well. The next one is laser ablation of anastomotic vessels. This is the advent that we have now thanks to fetal medicine specialists. So you block those anastomotic vessels and block those imbalanced way of fluid transfer from one sac to the other sac. Well, if you can't do that, if you don't have it, or in spite of doing that, still the problem persists, later in pregnancy, it's very difficult to do laser ablation. So you will have to resort to only amnioreduction to relieve the symptoms of the patient. So these are the 3 primary approaches, and I will tell you how to use them judiciously in different stages. So selective fetal reduction is another option, but as you can see here, it's a negative option. You are getting rid of one of the fetuses. Many people may not opt for that. It's rarely performed in the absence of discordant malformations or severe FGR. It's unfair for that particular fetus to die to save the other one. It is always better both of them are saved. The choice of approach depends upon the Quintero stage, the 3 choices: expectant, laser, and amnion reduction. So Quintero stage is very, very important. The maternal signs and symptoms are the other ones which will guide us. For example, if you cannot do laser, if the mother has got a lot of dyspnea because of polyhydramnios, that is the symptom. That will also guide us as to what to do. Gestational age, as I said, early gestation laser is easy, whereas late gestation laser ablation is not that easy. Availability of requisite technical expert. So it's not just the gestational age and the symptoms. You should have an expert who can precisely do this. You should have the machinery. You should have everything. What is this Quintero staging? It's very, very easy to remember. You can remember for life. Stage 1, obviously mild stage, isn't it? There is just oligopoly sequence. Of course, that's the starting point. Otherwise, you can't say it is TTTS, isn't it? So oligopolyhydramnias will be there. But look at, I've made the color code. Green is okay, red is not okay, isn't it always? The bladder of the donor twin is visible. That means the problem is not so bad yet. Sure enough, Doppler indices also are normal. What is that? Umbilical artery, uterine artery, ductus venosus, MCA, everything is normal. Stage 2, of course, oligopoly sequence will continue, but now bladder of the donor is not visualized. Now you realize why I was talking about look for the bladder in the monitoring. So here, bladder is not visible. That means it has become slightly worse. But Doppler is still normal. So we are talking about 3 things. One is oligopoly sequence, bladder, and Doppler. So depending upon what has compromised, you will stage them. Stage 3, oligopoly sequence will continue. Bladder is not seen, of course, but now you look at here. Abnormal Doppler indices, at least one of the following is present in either of the twins. That is absent or reversed end diastolic velocity in umbilical artery, reversed flow in A wave of the ductus venosus. This is the last stage. Pulsatile flow in uterine vessels. Now stage 4. Oligopoly will continue. Bladder is not seen. One or both fetuses shows signs of hydrops now. That is the thing. Stage 5. Any guesses? One or both the fetuses are dead. So it's very, very easy. Stage 1 is oligopoly sequence, which will be there in all the stages. We don't have to talk about that anymore. Whereas in stage 1, bladder is seen. Obviously, Dopplers are normal. Stage 2, bladder is not seen. Dopplers are still okay. Stage 3, Dopplers are abnormal now. Stage 4, fetus is now getting affected in terms of hydrops. Stage 5, fetus is dead. So depending upon the stage, we have to manage. In fact, there is a lot of options only in stage 1. Stage 2, 3 onwards, the options become limited. Now, stage 1 is further divided. I have given for the ready reference that bladder is visible, Dopplers are normal, everything is green here, except oligopoly sequence. The choice of therapy is based primarily on the severity of maternal discomfort from uterine distension, because that's the only problem here, oligopoly sequence. Cervical length is another problem because this increased intrauterine volume is going to put a pressure on the cervix, and we have to take care of that. So in stage 1, if the patient does not have symptoms of dyspnea, that means not so bad polyhydramnios, but cervix also is not at all bad, more than 2.5 centimeters, avoid any intervention. Probably this is the case or a fantastic or correct case for expected management, because there is oligopolysequence, but it is not so bad as to give rise to symptoms and not so bad as to make the cervix short. So you can just wait and watch the weekly monitoring, the 3-weekly growth monitoring, and twice a week Doppler is all that is required. To avoid inadvertent septostomy, if you try to meddle here, you may create a septostomy, and then there will be bloody amniotic fluid, which would make subsequent laser treatment difficult. Monitor the progress. That's all you need to do. Stage 1, no symptoms, cervix more than 2.5 centimeters, the same thing. But as you can see here, the management 18 weeks onwards, amniotic fluid, the monitoring, how do you do the monitoring? I told you to do the monitoring. 18-week onwards, amniotic fluid weekly, that is, change is seen in 11.1 days. MCA PSV, discordant values, PSV more than 1.5 MOM in one and less than 1.0 MOM in the other, are indicative of TAPS, which can occur in 5% of the cases. You must do Doppler of umbilical artery and ductus venosus as well. Fetal growth is assessed every 3 to 4 weeks. If there is selective FGR, Doppler of the umbilical artery and ductus venosus weekly. Also, you have to do CP ratio. But 30-week onwards, you will concentrate on, in addition to the above, BPP scoring as well, because by this time, the center that governs the NST in medulla oblongata is also mature enough to show the correct results. So BPP is started after 30 weeks in addition to what you have been doing earlier. This is the monitoring when there are no symptoms and cervix is long enough. Now, same stage 1, if the patient has debilitating symptoms and short cervix. That means polyhydramnios has increased, so much so that mother is feeling dyspneic and she has got symptoms, and it is putting pressure on the cervix and making it short. Here again, the division is, if the patient is 16 to 26 weeks, some people even consider 24 weeks, depending upon when you are confident to deliver them, laser ablation is an option here, because this has gone beyond the limit. This is a suitable case for laser ablation. You can also consider, if you don't have laser ablation, amnioreduction, simply to relieve the symptoms of the mother and pressure on the cervix. You may also consider a cervical stitch to hold on to the cervix and the pregnancy. But after 26 weeks, I told you right in the beginning, the laser option becomes less and less, mainly amnioreduction after 26 weeks. Because as I said, it's very difficult to do the lasers unless you injure the fetus and other organs. Laser ablation has technical limitations. Follow-up, as mentioned earlier, same thing, that is weekly Dopplers, BPP, and maybe growth chart. Amnioreduction is repeated if patient becomes symptomatic again, maybe once in 2 weeks or 3 weeks. Follow-up and care after laser. You have to do weekly USG first 2 weeks, then every other week until 30 weeks to evaluate the complications and response to therapy, both complications as well as response to our laser therapy. What are the things to be done? Amniotic fluid and fetal membranes are assessed to detect signs of membrane separation, inadvertent septostomy, membrane rupture, unexpected changes in the amniotic fluid volume. The oligo may become poly may become oligo. because you have created a hole now. Evidence of a therapeutic response. That's a good thing to see, whether there is reduction in the oligopoly sequence and whether the bladder starts now appearing. The results of interventions, overall survival with amnio reduction and laser therapy, if progression occurred, was 77% and 68%. Clearly, you can see the improvement. Laser as first-line therapy, some people have done straight away, 84%. Although these findings suggest laser surgery as a first-line treatment might have a small benefit, they are limited by the biases inherent in observational data. So if you have laser facility, go ahead. If you don't have, you don't have to do much in stage 1. How do you time the delivery and what should be the mode of delivery in stage 1 patients? As I told you, stage 1 is the one which you have to talk in details because there are a lot of options. The things are not out of control. If TTTS stage and symptoms remain stable, that means it remains 1, you can safely deliver them at 34 to 37 weeks like any other twins, in the absence of complications necessitating early delivery. That means suppose she develops preeclampsia, suppose she develops other complications, that is different. But otherwise, you can safely take them up to 34 weeks or 37 weeks and deliver them. The mode, of course, depends upon amnionicity, presentation, and obstetric indications. In other words, there's nothing special just because she has TTTS. It will be like any other twins, depending upon the presentation. For example, if the first twin is transverse, you may take a first section. And if there are other obstetric indications, like if there is placenta previa, if you think that there is fetal-maternal disproportion, if the first baby is a breech, there again you will decide to go for a section. Now, even though stage-wise they are different criteria, but stage 2 to 4 are managed the same way. What is 2? There is absence of bladder. What is 3? Abnormal Doppler. What is 4? High drops. They all almost going to the severe end of the TTTS. So they are managed in the similar fashion. There's no separate management for each of those stages. Just for your recall, I have written here clearly, no bladder and abnormal Doppler and high drops, 2, 3, and 4. Intervention is definitely indicated because it is severe. You cannot have expected line of management at all in stage 2 to 4. But poor prognosis is always met in expected management alone. Perinatal survival rates in an untreated patient, which was in the past, as you can see, before 1991, maybe when we didn't know much about laser and other things, only 30%. Whereas with therapeutic intervention, it has doubled, 60% is the survival rate. So definitely you need to intervene in stage 2 to 4. The choice of therapy, again, we divide the same way, 16 to 26 weeks, laser ablation of placental anastomosis as definitive treatment. That is the best. There's no doubt in that. But after 26 weeks, when laser becomes difficult, you can choose amnio reduction to relieve the symptoms of the patient and pressure on the cervix and follow up and care the same way as in stage 1, that is 3 weekly growth study, 2 weekly Dopplers, and after 30 weeks, weekly BPP, which includes the fluid assessment. Now I come to the management of stage 5. It can also be considered as single fetal demise. There's a separate talk altogether, but I will include that today itself, wherein the baby, one of the babies is dead. That is why it is called single fetal demise. Can also occur in dichorionic twins. You should remember this. It is not necessarily, it should be monochorionic twins. It can occur in a dichorionic twin also, entirely unrelated. So, but whatever it is called single fetal demise. But the risk of fetal death in monochorionic twins exceeds that in dichorionic twins and even singletons. SFD in monochorionic twins was threefold higher than the dichorionic twins. And SFD was more in monochorionic, that is 11%, and 3 in dichorionic before 34 weeks, according to another study. What are the concerns? SFD can cause morbidity and mortality of the co-twin. In fact, every single mother is worried, will I lose the other baby also? That's the first question she asks. In fact, we are also in a dilemma as to what to do. Should we immediately deliver them, or can we take a risk? And somehow everybody thinks that if I keep a dead baby inside, it is not good for me, both psychologically and all other reasons. Even if you think medically also, obstetrically also, there are problems with a dead fetus inside the uterus, something like infection or coagulation disorders. But I will clarify now whether to go for immediate delivery or not, or what happens for the surviving twin when one baby is dead. The fear is basically because of its shared placental circulation of a monochorionic twin or intrauterine environment that caused death of the dichorionic twin. See, if it is a monochorionic twin, you can sometimes justify your concern by saying because they were sharing the same placenta. But how do you explain the fear in case of death of one of the fetuses of a dichorionic twin? Now, the cause of death in a dichorionic twin may not be the shared placenta or a shared blood supply or a shared oxygenation. It may be a general hypoplacentation or hypoxia due to some other reason entirely unrelated to twins. For example, maybe an external factor, maybe preeclampsia. The prevention of single fetal demise is possible only if you do a serial fetal ultrasound to examine the stages and take appropriate action. Consultation and co-management with, as I said earlier, TTTS as per Quintero stage with maternal fetal medicine experts. But let us now look at, if it has already occurred, what are the effects of single fetal demise in monochorionic twins? They can cause following sequence in the co-twin, sequence, one after another. Number one, acute hypotension in the surviving co-twin, anemia, ischemia in the co-twin due to exsanguination into the low pressure vascular system of the deceased twin, resulting in morbidity, basically the neurologic impairment in 10 to 30%, and death in 10%. Yes, the fear of the mother is not totally unfounded. There is a chance of 10% death in the surviving twin. If not death, at least there is a chance of morbidity up to 30% in the surviving twin. And these things are because of ischemia in the co-twin, anemia in the co-twin, or acute hypotension in the co-twin. What are the effects of single fetal demise in a dichorionic twin? This is in the monochorionic twin because of the vascular connections. The sequence of hypertension, anemia, ischemia is not a concern since there are no placental vascular anastomosis, as I just now said. But then what is the problem? The problem is the death of one twin may reflect an adverse intrauterine environment that could place the co-twin also at risk for morbidity and mortality. I hope you are clear in this. The effect of single fetal death in a monochorionic twin is basically because of the vascular connections. But in a dichorionic twin where there are no vascular connection, yet the other twin is at risk because the factor that killed this twin is existing for the other twin also. Again, I will give the example of preeclampsia, the placental insufficiency, which has killed this one twin. As long as you do not deliver immediately, the other twin is also at same risk of death. I hope I'm clear. Early versus late single fetal demise. While the risk to the surviving co-twin is clear in late SFD, it is unclear with the early SFD, especially when it occurs in the very first trimester, what we used to call vanishing twin. If the fetus dies very early in pregnancy, in the past, actually, we never knew about this because we didn't do ultrasound as early as possible. When we first realized that she was pregnant, we saw only one fetus. So that's why probably the early fetal demise will not have much effect on the co-twin. Congenital anomalies and cerebral palsy may be attributed to early fetal loss. That means the one who died probably had congenital anomalies and maybe cerebral palsy. Congenital anomaly in the survivor following SFD before 16 weeks was more than twice. So if one fetus has died in the first trimester, you must look for congenital anomalies in the surviving twin. Probably if that is there, this fetus also may die. It's a matter of time. What are the consequences of SFD? A 120-gram reduction in the mean birth weight of the survivor, an increased risk of SGA, small for gestational age, an increased risk of preterm birth, because once one of the fetuses die, there will be separation little bit of the membranes and placenta, because that particular amniotic cavity shrinks and prostaglandins are secreted and they will get into preterm birth, labor. So how do you manage this case? We have understood what happens, but let's see how to manage that. It is same as MCDA twin without TTTS, which means no different. Now, why it is not different, let us see. Neither laser nor amnioreduction can prevent cerebral damage in the surviving twin. Now, whatever admixture of the fluid, whatever admixture of the blood, everything was going on till both the fetuses were alive. Once one of the fetuses dies, there won't be so much of admixture of the blood. At the time of death, it occurs. Sudden vacuum and sudden collapse, sudden anemia, sudden hypertension, all these things will happen. And that is the one which causes the brain damage in the surviving twin. But at the time of death, after that, nothing much happens. So there is no point in doing laser ablation, no point in doing amnioreduction, because there won't be much of supply from that particular twin. It is something like after the lute, there is no point in closing the doors or the gates of the fort. That's what I just now said. As the insult occurs at the time of the death of the co-twin. I have written in biggest fonts, at the time. But after the death, nothing much happens, the damage and other things. Of course, the infection, the coagulation factors, all those, like in any fetal death, that is there. But the direct effect due to the death of its co-twin will not occur after the death. It is at the time of the death. I'm underlining that. So what are the management goals? To optimize the outcome of the surviving co-twin, to avoid complications of iatrogenic prematurity. Why will iatrogenic prematurity occur? If you are in a hurry, the patients are forcing you to deliver quickly, and you also succumb to their pressure and you deliver them, there will be an extreme premature fetus. This should be avoided. A thorough ultrasound survey of the surviving co-twin for growth and Doppler of MCA PSV should be done. MRI 3 to 4 weeks following the fetal demise is indicated to detect any intracranial injury. That means you can go for 3 to 4 weeks even after the death of a single fetus. Intrauterine transfusion is not at all beneficial. Emergency delivery in the preterm setting does not improve the outcome of the co-twin. In fact, you will land up with a very premature baby. Maternal monitoring, of course, twice a week you have to do TCDC to rule out IU infection like in any other death. Coagulation profile again to rule out coagulopathy. Of course, it is rare. Other parameters depending upon the comorbidity. If she is preeclamptic, if she is diabetic, you have to monitor that. Miscellaneous issues, of course, you have to give steroids. You have to give magnesium sulfate prophylaxis if it is less than 32 weeks. Tocolytics if she gets into labor. Progesterone supplement, and bed rest, of course, is not beneficial. In fact, it can be harmful. Time and mode of delivery. In general, delivery timing must be individualized based on the clinical scenario. May wait for spontaneous onset of labor because now there's no fear of the other fetus. It's almost like a singleton baby, and you are closely monitoring anyway. Induction if there's evidence of deterioration of surviving twin or maternal condition due to her comorbidities. Cesarean delivery only for fetal distress or obstetric indication, for example, placenta previa or a transverse lie in the twin that is surviving and it is trying to come first. In a dichorionic situation, twin is not by itself a strong indication for early delivery of the surviving twin. However, if a condition affecting both the twin is present, again I am talking about preeclampsia as a typical example, chorioamnionitis another, then close surveillance and timely delivery of surviving twin are indicated. Timely delivery depends upon the condition, that is prompt delivery for chorioamnionitis versus expected management of preeclampsia without severe features before 34 weeks. So you have to individualize the patient. If the patient has got chorioamnionitis, prompt delivery, just preeclampsia without severe features, expected management like in any other singleton pregnancy. Monochorionic, the hemodynamic changes and brain injury that occur upon death of one twin are immediate, as I told you many times. Therefore, prompt delivery after death to prevent damage to the survivor appears to be futile, unwise. In the absence of maternal indication or another fetal indication for prompt delivery, delivery before 34 weeks of gestation is not recommended. Miscellaneous factors, anti-D prophylaxis is definitely to be given. Consider heparin therapy if there is active fibrinogenemia, related bleeding. And after delivery, keep the cord long enough for postnatal transfusion, which may be necessary for the survivor. Summary of management. After SFD,